Hey guys, good afternoon or good morning. We're so thankful you've joined us today. We're talking to Daniel about his experience in the neonatal ICU and now a neonatal nurse practitioner. You've been a nurse for 10 years, right, Daniel?
Yes. Hi, everyone.
A slew of experience. I absolutely love that. So NICU nurse as a traveler as well, resuscitation team, transport ground and air, as well as a PICU line team. I assume you were lead of the PICU line team. And then a nurse practitioner since 2016. I'm stoked to get to pick your brain and have you answer all of our questions. So what did I miss? Introduce yourself. Tell us a little bit about you.
My name is Daniel Brewer. I currently live in Charlotte. I've been a nurse for 10 years, like Chelsea said. The last 4 have been as a neonatal nurse practitioner. All of my nursing experience has been in the NICU, although I have a little bit of floating experience to PICU and mother baby. But and then I've led various roles throughout that time. So like Chelsea said, some of it has been travel, some of it has been transport. I was on a PICU line insertion team. I wasn't the lead, but certainly learned a lot during that and continue to do that procedure as a nurse practitioner. And then I've had an interesting education experience. I got my ADN, BSN, MSN, and now I am almost halfway done with my DNP. So yeah, just kind of working through being a nurse and the best nurse I can be.
It's amazing. So we're going to talk more about your DNP because I want to know more about what you're going to do with that at the end of the day. But tell us your funniest nursing story to start.
Well, I think I have several. One is kind of awkward, and I don't know how they'll feel if I tell the story, but they laughed at the time. But I worked with 2 nurses at a hospital before, and there was a group of nurses that lived in the same neighborhood, so they always commuted in on the same shift.
Nice.
Well, 2 of the nurses came in early, and you know, you kind of meet in the break room beforehand. The 2 of them had arrived there, and I was like the third one I was actually early for once, and arrived there. Well, I saw them flirting with each other. Well, I knew they were married, and I was like, oh my God, they're cheating on their husbands. It took me 6 months to figure out that they were married to each other. And I was, this whole time, when I found that out, I was like, I thought I had this like deep, dark secret about 2 of my coworkers that like I really wanted to tell people, but like I know I couldn't. But when they found that out and the whole unit found that out, they thought it was the like funniest thing ever. And so it was pretty interesting and funny, and in a way embarrassing for me too. But everyone got a really good laugh out of it.
So I have to ask then, how did you find out?
So like 6 months later, you know, it was literally like break room talk. People were talking about engagement rings, and I won't name names, but that was like, oh, when she got her engagement ring for her, I was like, oh, they're married to each other.
That is so funny. That's really,
yeah.
really funny.
And it made sense too, because like they could only be charge nurse at certain times, and you know, it was like, you know, all that kind of stuff. So after like everything clicked all at once, everybody was, you know, laughing at me. I was laughing at them. It was funny.
That is really, really funny. Okay, that's awesome. So when did you decide that NICU was where you wanted to go? I know you've done only NICU your whole nursing career. So what for you? How did you know?
In a way, it's what I chose. So, but I didn't choose it until I interviewed there.
Okay.
So what's interesting is, I wanted to be an ER nurse, and then I did my ER rotation through nursing school, and I was like, wow, everybody has a skin infection and is having a stroke and is an addict. Like that was my like slap in the face. And obviously that's not true, but it just seemed like, okay, this was not really how I thought it would be, like, you know, like CPR all the time, like, you know, other, you know, people. And then I also was, so I was like, oh, I don't know if that's going to be the right route or not for me. So that was one of my earlier rotations in undergrad. And then I did labor and delivery. I absolutely loved labor and delivery. I thought it was cool. I thought it was interesting. All the patients were you know, essentially under 50 years old. They were all women, but then you got to see a happy portion of healthcare too, with seeing childbirth and people really excited about it. And you'd get to see some sad parts too when they were born a little early too. But it just kind of seemed a little bit more happier than my ER rotation was.
Right.
And so, but at the end of it, my teacher, my preceptor for the mother baby, pulled me and one other student aside and said, hey, you know, you guys kind of had a niche for it. You dove in a little bit more than some of the other students. I'd be willing to write you a letter of recommendation, but if it's in women's or children's, I'll write you an even better one. So I kind of took that to heart. I got her information. I used her as one of my letter of recommendations as a new grad interview. And so I interviewed for several jobs. The only ones I got were for mother baby and for NICU. And my mother baby job was interesting because when I interviewed for it, it turns out the mother baby manager was out sick that day. So the director of like women's and children's, who I didn't know it was her at the time, I thought she was a mother baby manager, said, hey, that was a good interview. Would you want to interview for NICU? And I'm a new grad. I'm like, I just want a job. And so a week later, I ended up coming in and interviewing with the NICU manager. I ended up getting hired at both, which was nice. I did not get hired for any med-surg or critical care jobs that I interviewed for. I guess a better letter of recommendation maybe made a difference. And so I got a choice between the two. I thought after my labor and delivery rotation, I would want to do labor and delivery. So I was a little torn because of going, you know, that's what you had to do, mother baby, before going into NICU, or going into labor and delivery, but that wasn't, they were allowing new grads for NICU. So, so it let me, I was torn, and then it turns out the hospital was offering ICU pay of an extra $1.10 an hour, and so I chose NICU, and I figured, oh well, I'll get some experience at least with the baby portion, and maybe that could still bridge over to L&D if I wanted to do that. But I landed in like NICU and never left. So I don't think I ever will.
That's awesome.
Yeah.
There are not many new grads that have the opportunity to choose where they're going to go.
Yeah.
So I'm so thankful that you had that experience. It's amazing.
Yeah.
I think I'm echoing on your end. Could you turn your volume down a little bit?
Oh, sure.
I think it's coming through yours. Thank you so much. Do you feel like, would you recommend other new grads start in the NICU? What's your recommendation for those who
actually, yes. And something that is interesting about NICU is there is a lot of NICUs out there that want some experience for time management purposes, but it's a completely different world than anywhere in nursing, even mother baby, even peds. And so it, in a way, they kind of want to, a lot of NICUs like new grads so that they can train them almost right away the way that they want you to be trained. Everything, I wouldn't say you want to throw everything you learned out the window in school, but there is a huge learning curve as a new grad NICU nurse because your electrolytes and fluids might be similar, and then just like your tracheal suctioning, a little few things that you learn on the ICU side apart might be similar, but everything else is like completely different in a way, or it's at least minuscule and a little bit smaller math and double checks, and so it's definitely a specialized specialty. So a lot of NICUs sometimes like to train somebody fresh so that they can train them how they want them to be trained. In a way, you can see a new grad as not having any bad habits. So sometimes NICUs would see hiring a new grad as even an advantage so that you can be morphed into a NICU nurse rather than maybe another kind of nurse that has, you know, something good with one thing and maybe a little like distant on another. They kind of might carry that habit over. So I often find that a lot of bigger NICUs will hire new grads for that reason.
Yeah, I see that a lot actually in ICUs, where the trend used to be that they didn't want you as a new grad. They wanted you to get experience elsewhere. And now it seems pretty common actually that ICUs want to train you up in the way that they want you to do nursing as a whole. So I don't think that that's anything specific to NICUs across the board as it is. Brittany asked a really good question, which I think is valid. You know, it seems like there's a lot of nurses that want to go into the NICU specialty, and she's having trouble there in Nebraska finding a NICU role. Where do you suggest that she kind of branch off into what maybe peds or PICU? What do you suggest that would be a nice stepping stone for her?
Right. So, I mean, I definitely mention people like fresh new grads, but again, there's a huge advantage to hiring another nurse for time management purposes. One of my really close friends, he was an adult hemonc nurse as a new grad for a year and a half. Just got tired of losing patients that he got close to, and so I made him shadow me for 6 weeks. Well, he's in NNP school right now. So, and you know, they did hire him because he had that, you know, long, I mean, I think there's an advantage from anywhere in nursing. Certainly from the IC perspective, you'll have that acute critical thinking, but from like a med surge or regular floor, I mean, I don't know that I could even time how everything is being timed among your 8 patients sometimes. So you have better time management as a floor nurse. And then we often have labor and delivery and mother-baby nurses that will come in. Some of them can float, but they normally are taking care of like maybe the most stable patients that are going to go home within the next few days. So there's not a bad background. I don't or am not familiar of, say, somebody going from hospice or outpatient jumping right into NICU. I think if you can get some acute care facility experience, that would be a little bit more marketable, but that's just what I've seen in the past. That's not to say a manager might say, hey, that's an interesting background, you should come work here.
Yeah, Renee mentioned that NICU nurses at the facility she works at start in L&D and then bridge over, which I think is a really nice balance. So something I think is good if you can't get into a NICU, what about those specialties that float into NICU? What are most common? So I was a pediatric ICU nurse for 13 years, and my float bracket was NICU, peds, pediatric oncology, and PICU. I know not all hospitals branch that widely in terms of float range. So I think different hospitals have different float ranges, but would you recommend maybe you figure out, well, what floats into the NICU? Because then you can at least get your face in that.
Right. You can meet people, maybe even get to know the manager. And so with that, I would say PICU more so than even peds or peds hemonc, because they might let you take care of more than just maybe the baby that's going home tomorrow. Now, there is some L&D nurses that are like, you know, really good that have been in L&D for a while, and they're the ones always helping the NICU team out resuscitating an infant. And if they ended up somehow floating, that would help. I know like L&D censuses change so much and so drastically over the course of a shift that if you want to like work in a unit where you could get floated to NICU, PICU would probably be the easiest one. Maybe mother baby at a smaller hospital, but again, you'd be taking care of some of the more smaller, more stable patients anyway. But it's something you can ask as you interview for a new grad too. And I think everyone should do that regardless. They should ask if they will be needed to float or not. Something to consider is the NICU usually needs help because it's actually, no one knows this, but it's normally the biggest unit in the hospital. So,
Yeah.
and it's the biggest ICU in the hospital by sometimes 30, 40 patients. So depending on where you're at. So, I've seen, some NICUs are over 100 beds. So I think that that's kind of something to consider it, to be interested. And then PICU seems to be the one that would probably come and take a not super stable, but not super critical, like your moderate type patient, and then work a whole shift there.
Mm-hmm. Yeah, when I was on the float team, I was going to NICU quite a bit. Our PICU was low census, and so I was floating
Right.
to NICU quite a bit. And they were like, "Let's train you on micro preemies," and I was like,
Yeah.
"I'm good. Thanks so much."
That's my love. I love the little micro preemies that are like a pound and a half. But
Oh,
I know some people, even in NICU, like the older chronic, like trach and 6 months old, but still 8, 9 pounds kind of babies too. So
yeah, that's so funny. So Marie, she was just commenting here. She's a newer NICU nurse. She actually fell into NICU from a step down tele unit in adults.
Yeah.
And she and I were going back and forth. She messaged me and she's like, "What do you think?" I'm like, do it. So she got a job in the NICU there and she's loving it. So she's thankful she got to tune in today.
Yeah, and if you don't end up loving it, if it's not for you, then I feel like there's tons of adult jobs out there. In fact, my friend that had that is a former HEMOC nurse, who is now a NICU nurse that's doing NNP. He actually had to float to a COVID floor for about a month. So I mean, that's something he didn't necessarily want to float, but he was happy that he had that adult experience so he could go back and help. So something interesting to think about. Whereas I don't know that I'd be able to help the adult floors at all. But hey, the thing about this pandemic is babies are still being born left and right. That has not stopped.
Absolutely. And now with the quarantine, hey, we'll have nothing better.
Yeah, I'm a little worried. Even 6 months from now, when the micro preemies start being born, what will happen? I'm pretty sure our census goes up. And when I lived in DC, when there was a big snowstorm between 7 and 9 months later, you got busy.
There's nothing else to do.
Yeah.
Okay, so Carol wants to know, she wants to be a NICU nurse. That is her end goal. Is there a reason for her to go straight for her BSN versus her ADN? Do you see a difference in hiring?
I think it depends where you live.
Mm-hmm.
I did not. My program was a little unique. I didn't even know it at the time. And I don't even know that they have that program anymore. But basically, you were there for a year of pre-nursing. You did 2 years. And I was at a university. You did 2 years, and then you walked like after your junior year.
Okay.
And then you could stay for another year. But a majority of the classes were online, so most people didn't. They like walked, and I think 2 people stayed out of the whole program. So I walked. I thought, oh, well, I'll just do everything online. I needed a year or 2 to figure out how to be a new grad first, because being a new grad is tough. And so I think there is, depending on where you live. My first new grad NICU position was back in Eastern North Carolina, a little more rural, but one of the bigger cities in Eastern North Carolina.
Okay.
And so they were taking BSN prepared nurses. They were taking ADN prepared nurses, and then I know there's like that bridge programs too. They were kind of taking anyone. They were thankful to have a nurse.
Yeah.
For instance, so like where I worked at Georgetown, I got hired there as a ADN nurse, but I was in a BSN program, and I had my certification as a NICU nurse too. So that kind of had some other thing. It really depends on your area and where you live.
Right.
If the hospital near you takes a lot of community college nursing students, you might be okay. But if it's attached to a university or like, or magnet, you might need to have that bachelor. So if you're willing to move, you probably will find a job. But bigger university areas tend to have so much bachelor prepared nurses that they end up preferring that. And then there's also certain magnet qualifications that some hospitals also have to meet too.
Right. So I think the big push, right, as it stands right now, from what I gather, is that the big universities that are trying to achieve magnet status, they need to have BSN prepared nurses.
Right.
If you, those of you who are looking for a NICU position, do a little bit of research. Is that hospital trying to achieve magnet status? If the answer is yes, then you may need to go ahead and get your BSN. But don't let it stop you. Apply. All they can know, right?
Yeah, and I think, you know, like near my hometown in Fayetteville, North Carolina, there was, you know, two big community colleges, well-known community colleges that had their nursing students there all the time, in addition to a university there as well. So, I mean, they you know, they kind of had a mix of both, and not everyone was moving to that area of North Carolina. So, and they, almost all of them do have a requirement of within 5 years you do your RN to BSN. So just a heads up for those ADN, new grad ADN nurses.
And a lot of people say, like, don't lose momentum, go straight from your ADN to your BSN. Now, kind of, I agree with that for sure. What do you feel about nurses going straight from their BSN to nurse practitioner? What is
I don't agree with that either, honestly. And you know, some people are very like school smart, book smart. Some people, you know, pick things up on the floor. I think for me, NICU nursing was really, really hard my first 8 months. And I think a lot of people will say being a new grad nurse is horrible the first 3/4 of a year to a year. And then things start to click. You start finally figuring out your time management. You start finally figuring out, hey, this is what real critical thinking is. And so for me, it was just too much to go back to school right then and there for my BSN while being a new grad. But again, like I said, most places have about those 5 years. Now, when it comes to neonatal nurse practitioner, I don't know a program that will let you in as a new grad, as a new grad nurse. The school I went to requires 2 years of level 4 NICU nursing. I think someone went into the program with a year of NICU nursing, but had like PICU transport experience. Some people that have like busy L&D experience for like multitudes of years, and then maybe a year of solid level 4 NICU, they might be let in. But as an NNP, I don't know a single program that will let a brand new grad go right in without usually a solid 2 years of experience. And many are even looking for certification, NICU nursing certification prior to applying or at least completing that program. The caveat to that is you can work while being in NNP school. That last couple of semesters, it's hard to work full time. So that's something to think about too. You'll be gaining experience. At the minimum, you'll have 4 years of nursing experience by the time you become an NNP. So that's something to think about as well.
So since you've mentioned the certificate, why don't you talk about how you prepared for that exam and how long you were a NICU nurse prior to getting certified?
So in the NICU world, the main certification is the NCC, National Certification Corporation. They do, I think they do the NICU nursing and women's health nurse practitioner. And then obstetrics, I believe, too, RNCOB, so they require you to be a NICU nurse for 2 years as well. You don't have to be a level 3 or 4 or higher level NICU nurse, because there is a like special care or like step down nursing certification as well. But there's also like the Acute ICU certification too. I prepared for it. There's a wonderful lady named Linda Jareski. She has a class and an awesome book that tells you everything. I even used her book for some of my NNP board studying. So I'm not sure what's going on with her classes. It's called Nicu Solutions.
Okay.
I'm not sure what's going on with her classes with the pandemic, but if you can get a hold of just her book, it's kind of an outline of everything NICU.
That's great. That's really good advice. I'll link that here in the notes as well. So Marie asked, as a neonatal nurse practitioner, what advice do you have for NICU nurses or tips now that you're on the other side and writing orders for us and managing our patients?
Ooh, I think that is, I think that's hard, but I think a lot of it comes with critical thinking. I think communicating with us is key. You know, I do 24-hour shifts, so I've woken up before and I've had nurses say, well, hey, you know, this patient had, you know, several heart rate decelerations and events and all this, and I would have liked to know that, you know, kind of like overnight, where, hey, don't be afraid to wake me up, especially if you have concern. But I also don't want to be woken up or bothered because I'm managing so many patients and I have all of L&D, you know, in my mind, and also 10 to 12 patients as well. It's not that I don't want to be bothered, but if you can perform a nursing intervention before talking to me or a physician, first go ahead and do it. I've had times where nurses have said, you know, this baby has been having some desaturation events, or, you know, the work of breathing's gotten a lot heavier, and I've gone over to the bedside like really concerned, and the nasal cannula is kinked, or, you know, needed to be suctioned. Someone telling me, oh, well, even in mother baby or in L&D, this one baby had a low blood sugar. I'm like, okay, well, did you have mom pump? Did you start supplementing? Did you follow any protocols? And I think that that's something you want to notify the NPs and docs if you have a genuine concern. But if you can do a nursing intervention before notifying us, do those nursing interventions first.
Yeah. That's great advice. Use your critical thinking, do your assessment. Like, you assess, you notice something's wrong. Well, what are some basic things that you can do as the officer?
Right. Check the equipment, do an equipment check. And then just do, you know, there are nursing interventions that can be done prior to medical interventions.
Mm-hmm. Absolutely. So we're going to go back to just one more question about your schooling. How long were you neonatal NICU nurse before you went back for your NP?
Right. So I guess I'll kind of give you a little timeline. I worked as a NICU nurse for a couple of years in my hometown.
Mm-hmm.
Then I ended up moving to the DC area. I worked a year as a nurse at one facility, and then a year at another facility that was really going to help achieve my growth. They kind of like were like, oh, you have 3 years of experience, you want to become an NP? This was Georgetown, and they were like, okay, let's put you on the transport team. Do you want to learn how to put in PICCs? And so I think that was awesome to be a part of a unit that would help accelerate my growth and autonomy, and allow me to become more comfortable with going back to school. For me, 4 years was perfect, but I also had time to do all that, like learn different ways of doing things from 3 different hospitals, become part of like deliveries and resuscitations and committees and teams. And then I felt I was good to go back. Mm-hmm. And then during that time of going back for 2 years, I gained another 2 years of experience. And I think that was kind of really helpful. So 4 years before deciding to go back to school and having my certification and having more than just being a nurse, getting involved, and then 6 years of nursing experience before I became a board certified nurse practitioner.
So you said something that I think is really important. You went to a different hospital. I can't tell you how much growth I had going from a PICU that I was a baby nurse in for 3 years, and then I went and traveled as a PICU travel nurse.
Right.
My perspective changed so much, and I learned so much in that time frame. And I'm not saying that being a traveler is for everybody. It's not. It absolutely is not. But man, it opens your eyes. So even if you can just get a PRN job at the hospital down the street.
I agree. Absolutely.
Right? It's just so life-changing for your career anyway.
And you're a new grad for 5 years at a new hospital, kind of, it seems like. But when you go to another hospital with experience, they say, oh, you already have experience.
Mm-hmm.
And then you're automatically looked at as an experienced nurse. So the invitation and the welcoming to maybe have you do more things, more autonomous things might be there. And I think that it's helpful. I actually did my little travel experience. When I graduated my NNP school, I basically quit my nursing job. I did a couple travel assignments while I was waiting to do boards and waiting for my certification, because all that stuff takes forever. And so that's when I did it. But I still learned even then, after graduating NNP school, waiting to become a NP with privileges, I still learned by going up to the Boston area and doing assignments there. So I think that was kind of interesting and eye-opening too.
Yeah, that's awesome. And you say I was even learning. I hope we're all constantly learning, right? We should all be learning. Okay, so let's just talk just really briefly what you're training as a new grad in the neonatal ICU. What's that training like for general?
Yeah, most of the time it's 12 weeks. They should start you off a little bit on the slower side. You're taking care of the babies that are going to go home. You have 3 to 4 of them. They're working on bottle feeds. They might have an NG tube where you're going to give some NG tube feeds. They might have like a little bit of a nasal cannula every now and then. Some of them will have a G tube as well. And they were like the preemies that have been there a while and are getting ready to go home. Mm-hmm. Then you'll kind of, that'll probably be the first 4 weeks. The second 4 weeks, you'll start taking care of kids on CPAP or a high flow nasal cannula, a little bit smaller in the incubator, not really in the crib, not really bottle feeding, mostly all NG feeding, but pretty much stable. And then the final 4 weeks, you'll end up going with the babies who are on a vent, have central lines, PICC lines, arterial lines, have multiple medications, crazy stories, and some of them are, my last admission, I got, the mom was kicked by a horse, and she ended up going in a rapid preterm labor. That baby was sick right after birth. It was, so you end up seeing like the kind of the crazier stuff whenever you're on the ICU side, mm-hmm. But you also just see your standard baby that was born at, we're doing 22 weeks now. Yeah, 22 to 24 weeks, and they're just sick because their lungs are so immature. Or you might have babies that are 26 weeks, but you have quadruplets, and so they didn't grow as much because there's 4 of them. So that's when you start, those last 4 weeks, you really start learning into that, and then you're still learning. I'm still learning. So so you're still learning a lot. And like I said, that first year is kind of a little tough because it's like that anywhere in nursing.
So once you are off your 12 weeks of orientation, where in those levels do you fall as a new grad? Like, where do they put you at that point?
Well, I've seen it 2 different ways. I've seen it where, like, after your first 4 to 6 weeks, they then let you stay in the stable side alone for like a month, and then they'll put you back on orientation over on the unstable side.
I like that.
Yeah, and some people like that. And I've seen it flip back and forth even in the same units, and I don't know that there's a big difference other than like, hey, okay, now you're getting put back on orientation. And then sometimes shifts and preceptors and stuff like that. But I've also seen where you go all the way the 12 weeks through, they kind of start you with like some moderate patients, and then depending on how you're doing, if you're basically, it's kind of peer eval. If you need to go back to like the stable side for a while, and you'll be there for, a little bit longer, but on your own. Mm-hmm. Then work your way up to critical patients. I mean, that's kind of how mine was, where you know, and I needed that at the time too, just because I was a new nurse. I didn't have experience, and I needed to, I think for me, the huge issue was time management. And then around like 6 months that clicked. And then 8 months, probably the critical thinking really started clicking.
That's
So
awesome. And just communicating too, right? Like, I'm struggling with time management. Can I go back to the less critical patients and get my time management down, right?
Yeah, I really wish I would have, you know, I was a baby nurse. I was 21 as a new grad, and I just did not speak up for myself because I think I would have had a different approach. I did have a preceptor that was excellent. I had another one that was a little difficult, and I think that it would have been beneficial for me to have that excellent one the entire time. So, I mean, these are all things to consider for new grads, just to speak up so that you can be the best NICU nurse you can be, but also don't feel like you're failing either. Almost every new grad has that point where they're like, I don't know if I can do this, and that's normal.
Sure. And also, like, we don't jive with everybody. So saying,
No.
I think I can get a new preceptor. It's not like that preceptor's awful. You can verbalize it in a way that's not attacking to that preceptor, more along the lines, hey, I'd really love a different perspective. Can I get paired with another nurse? And when those questions of like, well, why? I would really love to learn from another person too. Right. So,
and a lot of places are giving new grad nurses a couple preceptors to learn a few different ways of doing things. So, and that can be helpful. It does kind of suck if like your first preceptor is amazing, you get along, you're learning so much, and then you go to someone that it might not be the case. And I think people's learning styles are different. I mean, think about in school, you have a teacher, you know, some people might have really loved one teacher, and other people might have been like, I'm not learning that much from her. and then it might be the other way from another teacher too. So it's kind of the same way with the preceptor.
And a lot of preceptors are voluntold, hey, you have an orientation today, right? It's not like you get to choose. In some hospitals, there's like a preceptor program. And I find that those preceptors, even them, they get burnt out because it's precepting after precepting after precepting. But man, when you get those nurses that actually want to be there, it's really, really helpful.
Yeah.
Okay, so let's move on to, well, I don't know if we have time. I would love for you to explain, if it's a brief explanation, level 1, 2, 3, and 4, for those who don't know what those levels are. Do you want to just?
Yeah. So I think it's the complete opposite of ER, I believe. So, yeah, so level 1 is essentially you're just regular nursery, that the babies are born, they're stable, mom's breastfeeding, they're okay. They might be able to do some like phototherapy. The babies might end up being in an incubator just for like being cold for a day. Then you have your level 2 NICUs, and where I work and in North Carolina, and some states might vary slightly, but usually that's babies that are born like above 32 weeks and 1,500 grams or so. So, but you'll still see some of those respiratory adult kids. You know, if you think about a baby that was born via C-section, there was no labor and no pushing of that fetal lung fluid around during the squeezing process of coming through the birth canal. So those babies sometimes can come out and have all that retained fetal lung fluid and even inhale a little bit of amniotic fluid, and they need some respiratory support because they're just tachypnic after birth. Those level 2 nurseries will handle that, but they'll also handle the 32, 33 weekers that might need a vent for a few hours and maybe some CPAP or some high flow cannula. And then it's really focusing on growth for those kids thereafter. So you get to see a lot at different hospitals, depending when you're at. Your level 3 will have your ICU, where it's usually, depends where you're at, 23, 24 weeks up, sometimes 22. And then those babies are just your straight up preemies. You might have a little bit of surgery, like you're like a pediatric GI surgeon. And then you might have like an ophthalmologist that can come on and do laser eye surgery. it's for retinas. The baby's retinas are really immature. And so you might have something like that, you know, where you have maybe a peds cardiologist can come do an echo, but you can't certainly go and do like cardiac surgery, or you can't do like, you know, a big procedure or anything like that. And so those will be the level 4s. The level 4s will have a lot of consult and surgical areas, some genetics available. It used to be that they had ECMOs, but we're getting away with that with advances in technology. So ECMO does still happen, but not as much with NICU babies. And it's happening so little that it's starting to be where the ECMO NICU babies end up either like going to PICU or the cardiac ICU, pediatric cardiac ICU too.
Okay.
However, like at Georgetown, those ECMO babies still stay in the NICU with the NICU nurses, and they are trained with ECMO too. So it kind of just depends where you're at as far as ECMO.
For sure.
So that's just the gist of it. But you can get, you know, a very busy level 3 that has a huge amount of deliveries. You could potentially see and do more and have more autonomy there. Then because you're stabilizing them and then shipping them off to those big level 4 surgical centers. So I know everybody wants to work at that children's hospital that's well known. Well, you know, you might get really good, valuable, autonomous experience from the large, busy community hospital that occasionally has to ship some babies there. So don't knock that down per se.
I think that's wonderful advice. I totally agree. So once you got your NP and you were done traveling, what did that orientation look like to now a nurse practitioner role?
So mine was only 4 weeks.
That's what I've heard.
They saw the experience I had and just how I picked things up as a new grad, and it was different. Mind you, okay, when you're a nurse in nursing school, you just do a couple, you know, a little bit here and there, and barely any of it's in the NICU, okay? Well, you've been working as a NICU nurse for a while now, right, by the time you become a neonatal NP. And then during school, your clinicals in school, you're doing 700 hours of NNP type stuff. So you're not as much of a new grad as a new NP as you are a new nurse. Mm-hmm. So I only had 4 weeks. The hospital I'm at right now, I think it was a very generous 12. But honestly, I don't know that it's needed as much. Okay. But it's actually nice to help because you almost just have 2 NPs, you know, an additional NP on for like the next 6 weeks or whatever. But usually it's not a whole 12 weeks unless it's like a completely different environment or very unique or specialized role, which then usually you need an NP experience already for. So.
All right, good. So Gina asked what the difference between a pediatric nurse practitioner and a neonatal nurse practitioner. She didn't specify if that was in terms of like your education or your role, but let's take the question more along like your education path. So can you do one and the other if you have?
I can probably explain all 3 because there's 2 types of pediatric nurse practitioners too. So for the neonatal nurse practitioner, it is all NICU related. You do kind of learn some things in school throughout the first year of life, but I would say you arguably learn more about fetal anatomy and what can happen during pregnancy that can affect a baby after birth than you do what an 8-month-old needs. I would have to look at a chart to figure out everyone's vaccines for the first 5 years in life because I only know the first 6 months. So, you know, it's kind of that, and you can't give this, you know, some of the same vaccines to a 2-pounder either. So, I mean, that all has to be adjusted as well. So, with neonatal nurse practitioner, you also learn a lot of procedures. You learn how to intubate, putting a breathing tube down. You learn PICC lines if you have not already done them. You learn how to do umbilical catheterization. You can actually use the umbilical cord after a baby is born, use their arteries and veins in there as access for blood draws and IV fluids. some places you learn how to do an IO, you learn how to do lumbar punctures, so you get to do chest tubes. So you learn a lot as a neonatal NP. Now there's and it's really focused on the NICU and the delivery room, because that's sometimes when babies can be the most sick, is right when they come out.
Mm-hmm.
Now, as a pediatric nurse practitioner, your focus is mostly from a primary or outpatient perspective, from birth as a newborn all the way up until 18. So now I work with PNPs often, because at the facility I'm at, they see the regular newborns while we see all the babies that are sick in the NICU.
Okay.
So anytime they have a problem with one of their babies, persistent hypoglycemia, hey, I checked this kid out and he's just not looking well, very pale, working hard to breathe, then they end up calling me over to reassess, and then we kind of decide if the baby needs to just be monitored closely in nursery or go over to the NICU.
Okay.
Now there is acute care PNP, and usually, and Chelsea, you might be able to explain these ones even more, but they're normally inpatient in the hospital, in the PICU essentially, and then sometimes they can work for a specialty in pediatrics, but are usually inpatient.
Mm-hmm.
Now I have seen two, I wouldn't say even a handful, acute care NPs work in a children's hospital that really needed help, and so they hired acute care PNPs, PAs, and NNPs in their NICU.
Okay.
If you, I've also, for instance, at Georgetown, where I'd worked before, the PNPs would see those stable babies that we were talking about, whereas they're probably just learning how to bottle feed, have an NG tube, room air, stable, okay. Those jobs are hard to find as far as PNPs that are allowed to work in the NICU, because you have NNPs where we have 700 hours of procedures, fetal anatomy, and learning about the birthing process, resuscitation at birth, where you might not necessarily learn about that portion of stuff as a pediatric NP or acute care PNP. You will learn a little, just not as in-depth as we do as NNPs.
If you get a PNP, is there something that you can do in terms of like some sort of refresher course, some sort of course where it's not like I have to go to a complete NNP program, but I could bridge over by, say, taking a test where I'm like dual certified? Does that make any sense?
No and yes. So usually what you would still have to have some NICU nursing experience.
Okay.
And then you would also have to do a certificate program as an NNP.
Okay.
Now, NNPs are so rare, and they're needed if you're willing to travel, that I've even seen advertisements for, will take an acute care PNP willing to get their certificate, but will let you like work in the NICU on like the stable patients and start learning to go on over. I think it was in Cincinnati where I saw that. Mm-hmm. But like I said, you would have to, you might need to move somewhere in order to find a niche like that. Gotcha. Usually you have to get your certificate to have the full scope and realm of the NICU from delivery room to discharge.
Makes sense. Okay. Marie asks, is there a difference between a neonatal nurse practitioner school and practicing as a neonatal nurse practitioner, like there is with nursing school and practicing being a nurse, as you were saying earlier? Or was it easier just because of previous experience?
I'm not 100% sure I understand the question.
I'm not.
Yeah, so a while back ago, when I was in grade school, and so this is pretty much before around like 2002, even maybe up to 2005, mm-hmm. There was nurse practitioner certificate programs, okay? And they would be like 9-month to maybe 12-month programs where at the time, remember, there wasn't as many BSN prepared nurses.
Mm-hmm.
So if a BSN prepared nurse went to a certificate program,
Yeah.
they could become a neonatal nurse practitioner. They are all grandfathered in. Now it's a master's degree or a doctorate degree. So you might, for instance, I still occasionally see BSN prepared neonatal nurse practitioners who took that like 1 year of additional training at a specific hospital or program. They got their certification. They became a board certified nurse practitioner. But over time, for all that work, you could have stayed another couple of months, gotten a master's, and that might now be an argument for a doctorate too. And so that's kind of the history. So you might see a bachelor's prepared NNP. They're probably going to be older than your parents if you're a new grad, younger nurse. So just kind of keep that in mind.
Gotcha.
And I'm not, if you have time to clarify, or if you want to Facebook message me a little bit more, I'll try to understand exactly what you're trying to ask too, though.
Sounds great. Okay, so Gina wants to know, is being a neonatal practitioner emotionally overwhelming?
It can be. I mean, I remember one night we did 7 codes, and that was a lot. Only I think 2 of the patients lived. Wow. And so that, that was a really like rough night.
Right.
And so Christmases are always bad for me. Every time I work at Christmas, it doesn't go well. So, I mean, when you have instances like that, that's really, bad. But the contrast to that is, say this baby that, mom got kicked by a horse, it went into rapid labor, and she's gonna go ahead and, a few months from now, if that baby does well and gets to go home, that's also so rewarding. And so there is very emotionally draining and difficult things that you have to prepare for as a nurse practitioner. Not only prepare for, but sometimes be the person as the messenger that tells mom what's going on that's not good with their baby. Mm-hmm. But the caveat to that is there's also so many good stories. I mean, and something to consider too, these patients sometimes stay 6 to 8 months in the NICU. You really get to know their families. I'm Facebook friends with a couple of my patients' parents, and I mean, it's nice to see that, some of my first patients are 4th graders now, doing great, and, running around having fun, and seeing videos like that encourages me on the days that I've had rough days.
Yeah.
And the mimosa always helps.
Absolutely. And I will just add something in for those of you who are watching. Don't Facebook friend your patients until they're discharged. Okay.
Yes.
Just don't do it. Okay.
They'll ask you questions all the time.
Okay. Marie did clarify. She said that similar to being a new grad, how it was like 8 months for you to get comfortable in your role.
Right.
Did you feel like you had that same transition period when you were an NP to becoming comfortable in your role?
It wasn't as bad, but it's because of all the autonomy I was sought out and experienced as a nurse. Yeah. Because I ended up doing transport, because I was a travel nurse, and some places when you travel, it's really busy. Here's your patients, and you got to find out where the bathroom is, Right. And so it was not as hard to transition. Have I noticed some people struggling with the decision making? Not as much. People know more than they think. I think it's a self-confidence issue when you become a nurse practitioner. And it's also just letting go of saying that you're bedside now and that you're now in charge. And just, it's really gaining that self-confidence. And some people that takes time. Other people, if they've had a lot of autonomy and bad experience, I'm a black cloud. So, I mean, it sucks, but a lot of, I've gained a lot. My 10 years has felt longer as a nurse. And so I think that that's something to consider. And what's funny is the people that I know that are new grads that might take a little bit longer time with self-confidence, they're like really good at procedures. And then, oh, they have a niche for taking care of withdrawal babies or like, congenital defect. They have their little niche. And so sometimes they just need a little encouragement of, hey, you're really good. And you know what you're talking about. You just gotta stop hesitating because you're right. And so I think for me, I didn't, it still took a little time, but it wasn't as rough. I didn't ever think, oh God, I don't know what I did. I want to quit. As a NNP, I was like, okay, I gotta learn that. I gotta be more confident in that. And as you do more and more procedures, as you do more and more similar decisions, I learned something the other day. You'll gain more and more confidence. So it usually surrounds self-confidence more than it does I'm a new grad and I don't know what I'm doing.
I think it's comfortable because you know what you know and you know what you don't know. So that line of lineation is like, hey, I need help over here. I don't know X, Y, and Z versus not knowing anything. As a new grad, you just doubt everything that you know or don't know, right?
All right. And with being an NNP, they require that Nicu experience. So it's not like you're just all of a sudden on an unfamiliar floor or place. Like, your way around a Nicu. You might not know the location of things if you become a new grad at a different hospital, but you know how to talk the talk and walk the walk.
Yes. So those of you who are tuning in, we're coming up on our hour. So we will be saying goodbye to Daniel. So if you have any questions, get them in. I just want to know one last thing because our hour went by really quickly.
We can talk longer if you want. Honestly, I'm okay.
Are you sure?
Yeah, I'm good.
Okay. So let's just go over, how did you make that decision to continue on to nurse practitioning school in terms of like balancing that debt to raise game? How did you go about that?
Well, it's school choice. Something interesting to consider about becoming an NNP, it is a little competitive. When I looked at it, I literally looked for weeks at NNP schools. I found 28 programs in the country.
Wow.
So it's a lot more competitive, where there might be hundreds of FNP schools and even PNP schools. There was 28. I think there's closer to like 35 now. So there, more and more schools are opening up. I think that I did the interesting ADN program that was still at a private undergrad school. And then I did a rather good but expensive RN to BS. And for me, I had gotten into 3 programs as an NNP, and I honestly went with the cheapest one. And I couldn't be more content because that school is well known. It was East Carolina University, and they're well known. They have an awesome director there, and it was just more affordable. Even though it was still out of state, it was still cheaper than the other 2 schools that I had gotten into. So I think there's no regrets. I don't think I had any lack of education or anything like that. And like I said, I think they're all pretty good considering there's so few of them, and it's such a specialty. And you can kind of, because you're a NICU nurse already and you have to be pretty much to go to school, kind of the questions to ask when you're interviewing for a program as well. So
that's good input. Are there any employers or any hospital jobs that will pay for you to get your nurse practitioning degree?
I was not a part of one. There are. Where I work for right now, there is a program. You have to be like a charge nurse, a transport nurse first. It normally takes more than just your easy 2 years to, not easy 2 years, but it takes a little more than 2 years to meet the qualifications to be a part of that program. Normally you owe like 5 years at that facility still. For some people, it's not a problem. They're going to live there. They know they are. Other people are like, hey, I don't know if that's going to go over that well or not. Then I don't want someone to sit there waiting for that. I don't regret paying for my NNP. And even so, I was still able to do a little bit of the education reimbursement at this hospital that I was at.
Nice.
So I mean, a lot of places offer anywhere from $2,000 to like $6,000. You can still submit that as a education recompensation, because it is, if you're working in the NICU and you're doing neonatal nurse practitioner classes, you're still learning about that same thing. So
yeah, moral of the story, learn how to play the system, because you really, there's funds there. You just need to dig at whatever facility you're at and figure out what's available to you, because I feel like they don't put it on blast for everybody to know what's available, because they don't want to pay it out if they don't have to, right?
Yeah.
So if you guys that are tuning in, if you're interested in advancing your degree, find what's available, because most times there is more than what's out in the open. You and I talked a little bit off screen about the difference between like a hospital job and working for a private company. Could you tell a little bit of information about that?
So, and this probably works for all nurse practitioners. So for instance, I'll tell you about my location right now. I work for the hospital right now. However, the neonatologists are part of MEDNACs, or pediatrics medical group. And so are the pediatric nurse practitioners, interestingly enough. My prior position as an NNP just outside BC, I worked for a small community-based neonatology group that consisted of probably 8 neonatologists and eight NNPs, and it was essentially like a small business. So you kind of had those benefits of a small business, which can sometimes not be as good, but sometimes the salary can be a little bit better, or there can be stipend. For instance, the way the insurance worked, you didn't get a monthly deduction. It was depending on how profitable you were at the year. You kind of divvied that up and then submitted it into your 401k. So, and that's usually kind of how it is with a lot of nurse practitioner jobs. You have your hospital based. I'm a part of the hospital physician group or medical group. But and sometimes they even hire you under the nursing realm. Often not, but sometimes they do. And then you also have these practices that the hospital hires to work in there. For instance, you might be a CRNA and you'll work for an anesthesiology group, but you work in the OR at the hospital. So there's a different realm of opportunities that people can have. That's usually the normal routes if you're going to work inpatient in the NICU.
Yeah, and I find too, pediatrics as a company is nationwide. And so if you have any desire to travel as a nurse practitioner, that's a really great route, because you can hire in with that group. And you get to go still travel, and you're essentially doing short contracts where you're needed. So there's so many options that so many people don't realize are out there. So Marie has a question. What is your weakness or struggle as a neonatal nurse practitioner, and how or what do you do to help yourself regarding it? And what's your strength, either in procedures or disease, your favorite procedure to perform, or what types of kids you like to care for? All right, 2 parts. What are your weaknesses?
Okay, so I think the genetic kids are really hard. There was a baby recently that I had that came out obvious Down syndrome, and I'm the provider now, so I have to be the one to break that news. It was unknown to the parents, and that is a pretty straightforward. A lot of people, you'll learn a lot about Down syndrome as a nurse and as a new grad NP. But breaking that news, then slowly introducing the idea of, okay, well, this is going to be the cognitive function, okay, and then saying, we need to check the heart because there's a high risk of there being a heart defect. We need to check blood work because you're going to have a higher risk of having leukemia. There's all kinds of interesting conversations that I think I wish I was better at talking with parents about it, but it's also just hard for anyone to comfort and explain those things to parents.
Yeah.
And that's with Down syndrome. Those, I mean, to me, those babies are really cute, and they have they have the greatest personalities when they're in the NICU. They're normally content. They don't scream at you. They're just as happy as can be. So I mean, some of the other kids that are, you know, the trisomy 18 is lethal within the first 2 years of life and often the first few months. So that discussion is difficult, especially when it's a surprise. And I just wish I was better at communicating people. And I'm a sucker. If the mom cries, I'm fine. But when dads start crying for whatever reason, it really gets to me. And I suck. I have to a lot of times leave the room and let someone who's a little bit better at comforting with it, honestly deal with it just for a few minutes. And I think it just sucks because now I'm in that role of being really the bearer of bad news. And I just wish I would, and I think with time I learned to be better with it, but I think there's also there's a strong hold where you can only be so good at that.
And I think too, you don't ever want to become so good at it that you're numb to it.
Right.
Because
you don't
relate to your patients well, or to in your case, your patients' families well. And so I would just encourage you to not continue to get better in that you're becoming numb. And I think that it's really valuable for those parents to see that it's hard for you too. Because if it's just like, it's no big deal, your kid's got trisomy 18, sucks, see ya. You know, like, obviously you want somebody that cares about you and your baby giving you that bad news. So kudos to you. It's okay that you have trouble with that.
Yeah, I think one of my strengths is I'm good with the difficult parents. I'll tell you this: anti-vax, anti-treatment, anti-chemical, antibiotic extremism has gotten out of control, and it literally touches the realms of the NICU every other day. I mean, it was anti-vax at first, and I'm like, you know what? They're small. You know, just get them when they're young. Get the vaccines eventually. But now, like anti-vitamin K, I mean that is something where you can have a serious intestinal or brain bleed and kill your baby just by refusing a shot. And people are saying, oh, well, my baby has an increased risk of jaundice. The studies are still being researched, but if you even did, jaundice is way more treatable than a brain bleed.
Sure.
And so I think that's kind of just you need to like negotiate with parents in a way. So I've been trying to become better at doing that. And in a way, that might be one of my weaknesses, trying to make it a strength. As far as procedures, I like intubating because it's normally, if you're doing it, it's very necessary. It's quick. It's not necessarily dirty. You need to be clean about it, but it's quick and to the point. I mean, you're just literally putting the breathing tube in and trying to help out. It can be hard. I feel like I'm good at it, which thank God I am, because it is an important procedure. I also like chest tubes, but they're kind of gross to do. So you hear like a little pop. I don't like doing lumbar punctures, but you can do them a good bit as a neonatal NP too. There's just something about that needle in the back that's just gross to me. And you feel a pop with that too. And so, yeah, those are kind of interesting. The others are usually normally central lines. One place I worked at, we accessed a ventricular access device, and we would actually have to, put a needle into their head and pull out cerebral spinal fluid. So,
in a lumbar puncture?
Well, so it was called a VAD tap, so it'd be a ventricular access device.
Okay.
And so it would almost feel like a little, like the end of a bulb syringe. Okay. It was almost like that's what it would feel like. And instead of, usually it's the kids where it doesn't circulate all the way down, but they're too small necessarily to have a VP shunt.
Okay.
So you would have to they put an access device in the head, and you can just draw that out. I only worked at one place that a lot of times the neuro team would do that, or someone, you know, sometimes even like a neurology nurse would come down from another floor and do it. But one place I got to do that. But my favorite procedure is intubating.
That's awesome. That's great. So this is going to be our last question. If you guys have any more, we better get them in. Let's say your favorite nursing hack.
So it's probably related to neonatal intensive care nursing, but when babies are born, they, you know, their body's transitioning from fetal life of being supplied by the mother, oxygenation and warmth and everything, to all of a sudden having to do everything on their own. So when a baby is born, our bodies are so unique that they really focus on blood flow to the vital organs and to your brain. So when starting an IV on these tinier babies, their extremities can be really cold despite them having a normal temperature.
Mm-hmm.
So usually we'll put a little heel warmer around their feet and we can prick their heel and draw some labs that way. We don't use those big bullets that they do on adults in the NICU. Usually we only need a 0.5 ml of blood for a full BMP or renal panel, bilirubin level. Same goes for like a CBC. So, and you normally just poke the heel and drip it a little bit on there. But if you're starting an IV on the feet or arms or legs, I like to use the heel warmer to try to get some more blood flow to that vein. Put the tourniquet on, leave it on there for like a minute, then take the heel warmer off, alcohol or you know, chlorhexidine or betadine, whatever you need to do, and then do your procedure, just so you have a little bit of more blood flow to that area that you're trying to get the IV on.
I love it. Great advice. Well, Daniel,
Yeah.
I have loved talking to you, and clearly everybody else has too. And we'll put the links that you mentioned for the neonatal nurse practitioning certification, or sorry, not nurse practitioner, sorry, neonatal certification. We'll put those links in the comments as well as your contact info. So thank you so much for tuning in.
Yeah.
All of you have an amazing day.
Yeah, awesome. And then if you guys have any questions, I'll try to answer them, but feel free to Facebook message me as well. Just, yeah, give me some time to respond.
Perfect. Thank you.
Take care, everyone. Become a NICU nurse.